So just whilst the slides are loading up, a big thank you to the Pakistan Society of Interventional Cardiology for their kind invitation for the meeting. Actually,
May I request all the people there with it having tea, please can we get silent, please? Because it's a wonderful talk by Dr. Sohail, so I'll request all my colleagues there standing on the sides to be silent, please.
Okay, so we'll get started here. Time is important. So actually, a slight change of topic here. What I'm going to talk about is actually the utility of intracoronary imaging in spontaneous coronary artery dissection. And I'm Dr. Khan. I work in Queen Elizabeth Hospital in Birmingham. So if you don't know where Birmingham is, of course, this is where we had the Commonwealth Games, which just finished a few days ago, and well done to Pakistan, who won 2 gold medals during that Games session. So just an overview of about the epidemiology of spontaneous coronary artery dissection. This is, of course, a non-atherosclerotic cause of acute coronary syndrome. And the reason why it's important is that it has a different treatment algorithm to standard acute coronary syndrome. Now, the true incidence of this is not really known, but if we go back and look at angiograms performed in patients who have a diagnosis of acute coronary syndrome, it is probably present in about 2 to 4% of cases. Now, if we focus in on females, particularly females under the age of 50 with an MI, we know that SCAD probably accounts for 1 in 4 presentations of patients in this group of individuals. So in terms of risk factor profiling, we know that being a female increases your risk, but also connective tissue disorders are important. So things like Ehlers-Danlos syndrome and Loeys-Dietz syndrome. And we know that actually if you do heavy lifting, exertional activities, that increases your risk of developing a spontaneous coronary artery dissection as well. There is this unusual entity known as pregnancy-associated spontaneous coronary artery dissection, which usually tends to affect the proximal vessels and also occurs more commonly in multiparous patients. The pregnancy-associated SCAD, however, accounts only for less than 10% of patients within the SCAD cohort. So what is the pathophysiology? So there are 2 sort of theories in terms of how this develops. So on the left-hand side, we think it may develop because of bleeding, rupture of the vasa vasorum into the medial layer, and you get this accumulation of blood, which then causes compression of your true lumen. The other possibility is that you get an intimal tear, which is shown on the right-hand side of the panel, which then causes accumulation of blood in the medial layers. Either way, we know that when this does occur, you get axial propagation of this hematoma, which then causes compression of your true lumen. And if you look on pathophysiological slides, often this is fibrin-rich hematoma that is present. So in terms of angiographic classification, most of what we see actually is shown here in the middle. So around 2/3 of the cases will actually have long diffuse smooth stenosis. And this is further subclassified into type A or B, depending on whether the vessel reconstitutes distally or not. Type 1 occurs in about 20 to 30% of cases and can often be mistaken for catheter-induced dissections. The other possibility is, of course, this could be due to streaming. So these are the main 2-1 cases. The third type, type 3, is actually angiographically unable to distinguish it from standard atherosclerotic plaque disease. And I think this is where intracoronary imaging becomes really important. In terms of management, we know that there is no randomized controlled trial in this arena, but what we do appreciate is that, certainly from expert opinion, is that we should probably adopt a conservative approach, particularly if the patient is hemodynamically stable. So unless they have ongoing ischemia, hemodynamic instability, or possibility of left mainstem dissection, we need to probably steer away from any sort of intervention. The risks of PCI are certainly present, so we know that even wiring of these lesions can be tricky. and particularly if there's an intimal dissection tear, you're likely to extend that further. But often when you do treat these with stents, you end up having to put in lots of stents into the patient's coronary arteries, and often those stents are undersized because you can't really appreciate the size of the true lumen, and in which case, obviously, restenosis is a big problem. So this is where I think intracoronary imaging is particularly important. So particularly if you've got a type 3 SCAD, where the coronary artery is not entirely clear as to whether this is a SCAD or not, I think IVUS or OCT becomes almost mandatory in my view. So in terms of the SCAD registry, so this was a big Canadian study which looked at 750 patients done over 20 North American centers. Actually, intracoronary imaging is not often done in these patients, probably in less than 5% of cases. Now, when you have two intracoronary imaging modalities available, IVUS and OCT, both have advantages and disadvantages. In terms of IVUS, we know that you have deeper tissue penetration, and it's probably less traumatic to perform in patients with potential SCAD. OCT, of course, you have to inject contrast into the coronary artery, which may, in theory, particularly if they've got a type 1 dissection, may extend the dissection flap further. So you have to be careful. These are both examples of SCAD patients. So you can see on the left-hand side, the IVUS shows quite clearly compression of the true lumen. On the OCT, it's a little bit more difficult to spot, but you can see that around 7 or 8 o'clock, there is an external compression of the true lumen which is going. So a couple of important cases which I wanted to share with you. Both females, the one on the left is a 55-year-old lady, the one on the right is a 65-year-old lady. They've presented with short episodes of chest pain. Both are troponin positive, and in terms of their ECG changes, they don't really have any dramatic changes on their ECG. Now, actually, on the face of it, it's very difficult to know which of this is a SCAD and which of these is actually due to an acute coronary syndrome presentation. So we know from the SCAD registry data that patients who present with SCAD usually are in their early 50s. So you could hypothesize that actually the patient with the SCAD is the one on the left, and possibly the acute coronary syndrome patient is the one on the right. But it's not until you perform intracoronary imaging that you can actually work out what's going on. So this is the first case, so the 55-year-old lady, and what we did here was wire the lesion and performed intravascular ultrasound. And here on the IVUS, you can see quite clearly actually what we're dealing with here is not a case of SCAD, this is a case of atherosclerotic plaque disease. So this is fibrofatty plaque within the proximal LAD, and you can see lipid pools within that plaque. So this was actually a diagnosis of acute coronary syndrome in this 55-year-old. Now, if we compare that to the case number 2, which of course on the angiogram looks very similar to case number 1, this is the 65-year-old lady. Here what we did was perform an OCT evaluation of the coronary artery, and when we did that, you can see in the middle panel, you can see that there's compression of the true lumen with a hematoma which is evident. And we went ahead and actually treated this with a cutting balloon. This is a technique to try and cause fenestrations within the intima to try and relieve the hematoma within the vessel wall. And we were successful in doing that. So low pressure inflation to around 4 or 6 atmospheres on 2 or 3 occasions, which was then able to release the hematoma. And you can see a very good, pleasing result on the right-hand side of the panel. Now, if we hadn't done intracoronary imaging, we wouldn't really have known which was the acute coronary syndrome patient and which was the patient with the SCAD. And often, if you treat these patients with stents, you have a milking effect where you can compromise the distal LAD or indeed even the proximal vessel and the left main stem and cause tooth pasting down the circumflex side branch. So the diagnosis here was a spontaneous coronary artery dissection. So different treatments depending on what you find in terms of intracoronary imaging. So this is my take-home message. So spontaneous coronary artery dissection is a rare cause of myocardial infarction, causing medial disruption and luminal compromise. I think we should all be aware of this diagnosis as interventional cardiologists, particularly if we're dealing with patients who present in their 50s and are of female gender. In the absence of chest pain, of course, the guideline-directed treatment is probably conservative, so we shouldn't think about wiring type 1 or type 2. I think where we need to perform intracoronary imaging, which is particularly important, is actually in the type 3 dissections, which we can't really determine are due to acute coronary syndromes or a type 3 SCAD. And I think here, intracoronary imaging really comes of its own. And this, of course, allows us to use novel treatment algorithms as well, including cutting balloon treatment, which can be used quite effectively, as I've shown you. So we've got a series of cases now, some which we've published as well in the literature, where we've used cutting balloon in such scenarios, which works very well. Thank you very much.
Thank you very much, Dr. Sohail Khan, to be just on time. So now we move ahead to treatment dilemma in interventional cardiology. As we had got 2 cases in session 1 for the ostial lesions, how to be treated. Now we'll be going for another discussion talks. First of all, when is the second stent needed in a bifurcation? So 2 stents versus a single stent strategy, when is it indicated? It will be case-based presentations for 10 minutes, and then we'll have panel discussion and audience interaction for 5 minutes. And the person who is going to give his talk on the first case is Dr. Naeem Hamid from Faisalabad Institute of Cardiology.
Okay, good morning to everybody. I'm sharing my slides.
Sorry, I think there is some I think those cases will be done later. It's Dr. Imad Sheiban from Italy. He's going to be giving us a talk. There is a little bit miscommunication. So Dr. Imad, you are on, and you can start the talk, and then we'll present the cases later on.
Okay.
Okay. Okay, thank you. Thank you very much. Thank you for the invitation.
Okay, so
thank you
over to Dr. Imad Sheiban for his talk. Thank you.
Okay. Thank you.
Dr.
Good morning
Imad, we
to
can't
everybody.
hear you.
Okay.
Can you just...
Let me
We can't hear
check.
you.
I'm not muted. I am online.
Yeah, you have to maybe speak a little closer, and I hope you are not mute.
No, I am not muted.
But we can't, we hear you, but it's very low voice. I don't know your, the mic which you are wearing, or you need to come closer.
No, actually it is.
Yes, it's better now. It's better now.
Okay. I'll try to do my presentation. Thank you again very much for the invitation. I'm speaking about the need of a second stent in bifurcation lesion. So we know that bifurcation disease, we have different scenarios, and we have guidelines for the treatment stating that provisional stenting would be the preferred approach for most bifurcation. Exception, that means the use of 2 stents is limited to large side branches, that mean more than 275 millimeters, with a long ostial side branch lesion, with a 5 millimeter or more than 10 millimeter, and anticipated difficulty of accessing an important side branch after main vessel stenting, and through distal bifurcation lesion. And again, by syntax score, this the Medina 111 will add 100 and 10, that means simple will add only 1 point, while through bifurcation will add 2 points, and the angle will add an additional point as well. But we know that the first step is to evaluate the clinical relevance of side branch. That means the size and length of side branch as well as the whole territory branch supplied by that branch. As you can see here in these two examples, when you have a small side branch, then it is just to keep open. But if you have a large side branch covering more than 10% of left ventricular mass, then should more attention should be paid for that. And angiography alone frequently underestimate side vessels, so intravascular imaging is very important to be used in order to quantify the side branch importance. Provisional stenting, actually, we always should focus on how much myocardial mass at rest. As you can see in this example, a huge diagonal was included after stenting the main vessel, and this was immediately ST elevation when the side branch was recovered, then everything been coming back in place. And you can see that this might happen in at least 22% of cases, like what was coming from EPC main study. That means shifting from provisional to stent. And this is because of side branch occlusion during bifurcation PCI can be caused by carina shifting, flag shifting, but most importantly, dissection with always or quite always will need a second stent and spasm as well. Of course, so the side branch size does matter in deciding whether one or two stents. The angle also does matter, as well as the length of lesion, as have been coming from DK crash series from this study, from this analysis from Zhao and also coming from this meta-analysis showing that if we have a long lesion more than 10 millimeters on side branch, then two stents approach is superior to provisional stenting. And we have seen from Zhao the definition criteria, and based on definition criteria, we can define simple bifurcation, which will be much more beneficial than two stents if the bifurcation is defined simple. But if we have complex bifurcation accordingly to definition criteria, then two stents will be definitely superior to single stenting. And also this was confirmed by definition two studies as have been shown previously by my friend Zhao. So to summarize, I think bifurcation lesion, when we have clinically relevant side branch that mean more than 2.5 millimeter size and the length more than 70 millimeters, or distal lift main where side branch is almost main vessel, then if it is not relevant, just keep it open. If it's yes relevant, if it is simple bifurcation, then go for simple elective stenting. And if it is complex, accordingly to the criteria we have mentioned before, then elective complex stenting, that means upfront two stents, should be used. And of course, intravascular imaging is always recommended for procedural planning, guidance, and optimization. Of course, another important point is lesion preparation, and we should do every time our best in order to have a good preparation of the stent of the lesion in order to have a full expansion and apposition of the stent. As you can see in this example, when you have that much severe calcification, then if you are not preparing the lesion, you will never have good expansion of the stent. And intravascular guidance, again, as have been mentioned before many times, and we have a lot of data showing, supporting the use of intravascular guidance, which will give more benefits for on the clinical outcome. Now we have all these different approaches in the bifurcation, that means starting from simple provisional or complex, whether it is T family or crash, mini crash or DK crash or pull-off, all are effective. But of course, the operator experience in a single particular double stenting technique is probably more relevant than the specific technique itself. And this is also shown by meta-analysis comparing all these approaches. And what is we can see here from the final scoring ranking system, that you can see that each approach will have pros and cons, but what we can of course see that TK crush in two-stent technique will be the best approach because it has only one contrast but more pros than contrast. While if we look on crush, we'll see that conventional crush, we'll see that more contrast than pros. And of course, we have had an evolution of strategies with the contemporary stent platforms, and we have this was due to more detailed data coming from bench testing and clinical practice, more use of intravascular imaging during the procedure, more effective devices for lesion preparation, improvement of basic strategies, and more clinical data with improved outcome. I'll show very quickly different cases done with different approach, like but all guided by intravascular. And you can see that provisional stenting, you will have, if you are going stepwise, you will have an excellent outcome which is, when it is indicated, as well as T-tap stenting will give you good and excellent angiographic and intravascular imaging optimization, as well as Tock stenting, as well as DK crush stenting in this case, or mini crush stenting in this case. So my final remark is a second stent is needed, shifting from provisional stenting for side branch bailout. Upfront two-stent strategy is based on side branch clinical relevance, lesion characteristics, that mean disease severity and lesion length. Definition criteria for simple and complex bifurcation seems to fit with an appropriate strategy selection, which when we have simple bifurcation, then simple stenting, that means provisional. Complex bifurcation should go upfront complex stenting. Two-stent strategy, all strategies have their pros and cons, but no doubt about the need for good clinical experience, good technical experience, stepwise approach, planning the procedure accordingly to lesion characteristics and complexity, lesion preparation for a good stent expansion of the position, optimization, which is mandatory and associated with a better outcome. And finally, it is essential to have a good experience in more than one two-stent strategy and to be ready for plan B, which might be necessary during the procedure. Thank you very much for your attention.
Thank you very much, Professor. Now we'll be going for the first, just to be on time, thank you very much. Now we'll be going for the first live case of Pakistan Live 2022. And we'll be taking you, first of all, before we switch over to the cath lab, do we have Dr. Rosli Mohammed here? Dr. Osman Fahim? So can you just join us in the panelists? Dr. Rosli. So it's a live case from China coming up. So we would like to have you be in the expert panel. So the first live case for Pakistan Live 2022 is coming from Fuwai Hospital, Beijing, China. Send over to the Fuwai Hospital, China. Are they there with us? First of all, we see them, then obviously. So this is a joint session between Pakistan Society of Interventional Cardiology and Chinese Society of Cardiology, and we have got Xiaoleng Chen representing from China, and the case is coming live from Fuwai Hospital, Beijing, China. We are just waiting to be hooked up, and then we'll introduce the operators there and obviously the case.
While we're waiting and we have Professor Chen with us, whenever we talk of DK crush, we talk about you and your experience. What made you come up with this concept of DK crush and how you did your studies, and how come this study of yours is used as a benchmark? Nobody has done such systematic review of any other two-stent strategy as you have. So what really made you think of this, and what were your thoughts, and how did this journey to DK crush evolve?
里面看不到 PPT 是吗？在这儿吗？在这儿给我打开呀，我看看有关的照影。慢一点。
So are we live?
在上边是吧？对，上面一点点。
I can hear them, but obviously not see them right now.
We'll see them shortly, I think.
Yep. So now we have got two of the operators there at Fuwai Hospital, Beijing, China. It's Professor Yongjian, who is the director of Fuwai Hospital, China, and along with him is Zhao, who is the associate director of the structural program for Fuwai Hospital, China. Can you hear us, Dr. Yang? Dr. Wu, can you hear us?
已经开始跟我们打招呼了。我们先不说话，先那个什么。
Dr. Wu, can you hear us?
什么？哎，是这儿吗？就这儿。我们先口现在口连有都没有了，比上次还有点。上次还有一点口，这个就是没有了。
Hey, Yongjian, can you hear us? Yongjian, this is 少亮。
那你围着我顶着呢还是啥？
你能听得见吗？
我们先照相啊，都打30、30。
From Fuwai Hospital, Beijing, China.
看不见。那给我先。你推这边，我推这边哈。我推这个，你推这个，你推那边那个。哦。先对选项了。再见。我觉得不行，我们就换一个，又4算了，拿个724， 724吧，那个改进了，找一下直接开。 724来，要不就是改进了来。
Because you know them, would you help us moderate with those?
在下面。
永健，你听得见我说话吗？哎，永健。
哎，喂。
哎
，Hello。
哎，永健，你听得见我说话吗？
是陈院长吗？陈院长你好，喂。
你好，是我。对，现在。
我是赵杰。
哎，现在你们。
我是赵杰。
现在你们可以用
我们上一台。
现在你们可以用英文跟主席进行交流，他们现在在等着你们的声音。
我们正好刚刚转过来。Hello, everybody. This is Fuwai Hospital from China, and I'm Dr. Zhao Jie, and this Professor Chen Jing. Now we are together to have this case from here. It's our honor. And first of all, I think I'd like to invite Professor Chen Jing to give a very brief introduction of this case. 你介绍一下这个病例。Okay.
Thank you, Professor Zhao. First of all,
okay, I will introduce this patient. This is a 64-year-old male. He suffers from upper chest pain for 1 year. He has a typical risk factor of hypertension, diabetes, and smoking. And his echo and his blood test is normal. And about 5 months ago, we have done angiography, and the angiography shows LAD and RCA CTO, and we have finished PCI 2 LAD with the V stents. Next. Okay, this is angiography. As you can see here, the LAD is total occlusion in the middle part of our LAD. Next one.
已经开始了是吧
？Yes. This is the procedure we finished. We had done PCI. Okay, next one. Okay, this is the final result of the LAD. We implant 2 stents in LAD, and the result is quite good. next one. But still, we have work to do. This is so we leave it today. This is a CTO, total CTO in RCA, and we'll just CTO score is 3. I think it's quite a challenging lesion. Now, shall we discuss our patient, our strategy with our friends online in Pakistan? Professor Zhao.
So this RC you are going to try today, is it?
No, it's Professor Yongjian.
You told us about this case that you
is here.
stenting to LED in February 2022. So what about the RCA? Were we seeing the past images, or are you going to attempt the RCA today?
Okay, can you see clearly from the picture, the imaging? Now I think the proximal cap of RC is much more serious than before, than half years ago. Half years ago, we can see a very short lesion. 那个动起来，把那个动起来，那个图像要动起来。
Okay, we'll get comments from the panelists from Pakistan and people sitting here, the international experts. So the question before the panelist is whether to go for an integrate or a retrograde approach for this RCA.
I think before we ask the panelists, the double stick does show you some integrate flow, and but initially the diagnostic looked like a very blunt, ambiguous origin, and retrograde was a very good option. Now you see an integrate, of course, double stick will come in handy. The stent left system would make a retrograde a little tricky, but it's still possible. So I think one has to be integrate, but it is worth attempting an integrate initially. That's my initial thoughts. So,
Thank you. Yeah, I think the CTO lesion length is not too short, but still there is a chance to try to open RCA from antegrade approach. Also, the collateral from left to right is pretty good. So if you fail to open RCA from antegrade approach, I think there are very high success chance from retrograde. Thank you.
Rosalie, your thoughts?
I can't really clearly see from here, but it looks as if it's going to be quite difficult for an antegrade attempt. And retrograde is more likely to be the option, or rather the technique of choice. But I will still try an antegrade first and to see how it feels like before changing to another strategy.
Any other you want to comment?
Yeah, so it's a very challenging case, and I think the important things here are to perform dual angiography, which they've done, because what you're wanting to do is to look at the proximal cap to see whether it's tapered or not, and also to assess the lesion length here. And the lesion length looks quite long to me, so I can't see if there's any calcification within the vessel wall, but this is probably a JCTO score 2 or 3, which puts it into a higher degree of complexity. And the other assessment that needs to be made is whether you've got collateralization of the right coronary artery, and whether those collaterals are septal collaterals or epicardial collaterals. It looks like there's a marginal collateral that's coming off from the left, but this is going to be challenging. So I would probably attempt this as an antegrade approach as a first off, and then think about retrogrades secondary.
No presence of an anchor vessel on the very obvious change to implants or stick to a judgment.
I think what you have to use is a guide that you're familiar with, and I would probably go in with a 7 or 8 French guide into that right coronary artery to give myself more options. As you say, what you're wanting to do is to assess whether there's any way you can anchor proximally. But if you've got a big guide, you don't always need to put in an anchor balloon. So I would approach this with a microcatheter, workhorse 135 microcatheter, and probably try and probe the proximal cap with a workhorse wire to begin with, and then escalate to a polymer jacketed wire, probably something like an
Probably
XTR.
started with an implants 0.75 maybe, and if that had difficulty in sitting,
then I'd
probably think of Judkins just
对，好好谢谢。
to get as much support as
1.5的
possible.
球囊，拿1.5球囊压力泵，开个1.5球囊。
这两点开始，咱们上一台手术，然后一下子做的刚刚上台，所以上一台手术的 CTO 做的有点长的时间。所以这个。
May I speak Chinese?
不好意思啊。
所以用。
不好意思。
那个赵大夫，哎，你们听得见我说话吗 ？No。
请能进行不错。
No。哎，永健，你们听得见我说话吗
？It's very the signal is not good. Is
现在能听得见我说话
cannot hear clearly from the audience. 啊，哎，我觉得这个可能。
那个赵大夫。
So Dr. Chen, why are they not using an implants? And they're gonna just go integrate. Would an implants be the advantage here?
信号不行。
信号不好。
Yeah, I think Judkins guiding is terrible. So further we need to use EBO or XBRCA or even implants. I think they're the better one. So from the image you can see this is Judkins, right? So coronary B is stabilized. It's terrible for CTO. Also, according to the angiography, no more very severe calcification in right coronary. So I think still there are high chance of antegrade approach. May I ask them in Chinese?
Of course, you just talk to them.
Yeah, because you know now the connection is unstable. 永健、赵杰，你们听得见我说话吗？ So no communication.
里面就是派了150。
这150吧，不要那个。
这就是150。
对。上次右冠近端还有个墩儿，这次什么都没了。
Because no communication. They cannot hear me.
信号的事儿问一下。
哎，永健，你们听得见我说话吗？
信号是。
哦。I ask them 20 times.
Are they anchoring the Judkins now?
我们只是
this wire side branch for the anchor?
Yeah, because they could not hear me.
Okay.
Yeah, they could not hear me. No communication. 哎，永健，哎，吴永健。
从那个逆向 root
直接总结。我先试试。
用撕裂的方式。
我先试试前向，因为上次经常还有一个比较好的一个墩儿，这次什么都没了。
你那个不行，这样的不行，这样的找不到那个前向的那个方向。
试试。哎，你别走，你不要走，我来走。问 Tock。试一下，能把上次那个弄出来，过去也好。我感觉那个 Unplus 都做不上去了。
但关键是不能够做，这是。
上次还看得还比较清。
我们在做，他那边有那个信号，那边的那个信号不好，我们就
I think there are some challenges in terms of communication with the lab. So you know what we can see here, just to sort of fill you in whilst we get those communication channels back, is that they've got a Judkins right guide, it looks like, in the right coronary artery, and they've obviously been struggling to put that into the vessel. Now, what they've done is they've put a wire into a small branch there to give themselves some anchor options, just to stabilize the guide. But as you suggested, one of the other options would be to think about a more supportive guide at the outset, something like an Amplats. That may have been a better option. Yes, I think that's it looks like that's what they're trying to do. And this is always a challenge because remember these cases are going to go on for quite a substantial length of time, and what you don't want to do is to lose your guide support when you're working through the case. So you really have to have a supportive guide at the outset.
It's very important to have the implants, especially 0.75 with side holes, so that you get all the good support you can.
Yeah. I mean, the side holes is an interesting one. I have to say, I tend not to use side hole catheters.
We all know the pressure coming is having the integrate flow, but it is a very good catheter to have for CTOs.
Yeah, but Amplats, I agree, is a very supportive catheter.
You must know the shortcomings of Amplats and getting side holes, because the side holes will give you the pressure, but the antegrade flow tends sometimes to be reduced. But you know, if the side holes are fairly close to the catheter, they will be antegrade flow.
with site holes, you got to be careful because contrast fuse goes
I
up
think just
pretty
commenting a little bit on this antigrade, the chance of at least me getting into this antigrade is extremely low, as far as I'm concerned. Unless you have all gadgets and anchoring and everything. The problem with implants is it doesn't, when it engages, it really wants to go as deep as it likes. But as long, to get it coaxial is sometimes a real problem. And my other question is how much time does Chinese give to the, how much time would he dedicate to this antigrade and then switch to the retrograde?
I think it's a very personal choice. And to me, a CTO,
Sorry for interrupting you. Sorry. Yongjian. 吴永健。
喂。
哎，永健，你听得见我说话吗？
我那个信号，那个信号一直在断断续续的，这边这个信号很糟糕。
也，那现在你们能不能介绍一下你们的这个手术策略？
喂。
听得见我说话吗
？Sorry.
I'm sorry. 哎，永健。哎，你现在听得见我说话吗？
哦，现在我听得见，就这一会儿啊，这个信号都特别不好，一直都没有听不见会场的那个，因为那个信号一直都是断断续续。
现在这样，永健，就是你们尽量不要用中文谈话。第二个，现在你能不能介绍一下你们的这个手术策略
？Okay, so it's the Okay, so I'm Dr. Wu. So now, so the Professor Zhao and his team is the performing this the procedure. So maybe the first of all, I talk about our strategy for this patient. So this the lesion is different from before because the 2 weeks ago we selected this patient, and so the CTO lesion just located the proximal RCA, but now is included as the osteo of RCA. So it's very difficult for cannulation. And now is the Dr. Zhao tried to use the new guide catheter and to try for the cannulate, but I think it's very difficult. Maybe we should change our strategy. Yeah, and so I wonder. So maybe the panelists to give us some suggestions, because now it's very difficult to find the osteo, the right the coronary. So maybe we will switch to the retrograde, and we try to make retrograde wiring and to the through septal to the right coronary, and maybe we can use the snare for the wiring, for the retrograde wiring. But first, but maybe so now the doctor want to try again. Maybe do you think now is
I'm not sure it's
already in the right coronary?
I'm not sure it's the ostium of RCA, but it's really unclear. Half years ago, we just. So
now it's clear?
No,
so can you hear me?
我知道变了。
我们能听见你说话很清楚。
Okay.
那边断断续续。
Yeah. So I'm struggling to hear, but I just wonder whether the ostium of the right coronary has been dissected, which is why they might be challenged to try and find the ostium of the RCA now. They've clearly changed guiding catheters, as you'd suggested, and trying to see where they want to go. But I just wonder, rather than waste time here, whether they should just now switch to a retrograde approach and have a mark wire in the distal RCA to see where they're going.
I think the Judkin isn't likely to dissect the right ostium. the implants has a good chance of dissecting it. They haven't engaged the right so far, so it's not a question of dissection, just a very small stump which they couldn't engage. But I think they want to give the antegrade a fair chance. It's fair enough. It varies from person to person how much they want to spend time on it. But to be honest, CTO is not about getting the guiders in, and it takes an hour sometimes to just get your guiders in place. And you should not rush through this. You have to be very patient, and CTO is about patience. You should not run out of patience and jump from one to the other quickly. It needs to take time and feel comfortable. I think I would...
It's still not clear. And so, Professor Chen, can you hear the voice from the meeting? Xiaoliang, can you hear the voice from the meeting?
With the CTO, you want to spend as little time as possible wasted. And I think, they've done a lot of screening here already. You've got to change strategies. So you either go for a dissection re-entry strategy. If you're going to go for that, you're going to have to get your guider in. And the only option is to go retrograde now.
Yes, of course. Retrograde.
Yeah, don't hurry.
The way I see these guiders moving and going in now, these guys are very trained, high-skilled, Formula 1 kind of CTO operators. So I'd give them the full chance. I'd like to see how they work.
You're a lot more patient than I am.
赵大夫，你们现在用的是什么指引导管，什么导丝？
少良，你能听得见吗？我怎么听不清楚这个？
哦，永健，就你们现在用的什么指引导管，什么导丝？这指引导管好像很难到位。
什么？
I think even for your retrograde approach, you would need to have a guide catheter in the ostium to recapture your wire. So it's important that there is a guide or some catheter.
Yeah, so I think now we should switch to the retrograde. Yeah, because it's very so because the Dr. Zhao tried the different the guiding catheter. It's not easy. So
宝马是吗？宝马放到那个鱼导管拿了吗？150的，150的。
So I'm sorry, so because before this the lab demo, so and one half the CTO is just finished, so we have enough time for preparation.
I think one must appreciate the complex CTO which they've chosen for a live case. Now, we knew it's going to be a challenge, and to take this on as a live case, is interesting.
Yeah, exactly. It's for CTO lab case. Sometimes we need to spend 45 minutes to manage the guiding catheter, probably 10 minutes to open the CTO lesions. Is it true?
So getting the guider is
right, exactly. So 永健，你们现在能听得见我们会场吗
I think getting the guide is the most difficult.
我现在就是那个就是那边吱的拉就是听不清楚。按照会场的声音不是太清楚。
Sohail, can I make a comment?
Yes, of course, please.
Yeah, I think in these cases, like using this as a guide to try and get into the right, I think the best thing would be to use a JR, another prick, have another prick. You can use the other radial or the femoral, and use that as a thing to get into get the AL in, because what they are trying to do, you're not sure where the ostium is, and with the JR curve, they were quite easily they got into the thing. So I think just leave the JR in the cusp and give a few puffs while they put the guide in.
I think they started for the retrograde. They heard you guys, so their patience lost, and they're going retrograde.
So it
would be a good retrograde to see going through the struts. Would you open the struts before you put the corsair in, or just like go in with the corsair without opening the strut?
Seng does.
Usually, from a retrograde approach, we need to use a balloon to dilate the orifice of septal branch. And also after that, once the microcatheter coccell into the septal branch, and still there are some very strong resistance, we also need to use 1.5 or even 1.25 balloon to dilate. Yongjian, can you hear us?
I think it depends on the LED stent size too, because some struts are smaller and you got to adjust it a little bit.
So
what are you doing?
So because the anticrate is very difficult because of the guide caster is not in the position, and now so we switch to the retrograde. So so from the angiography, so the channel from the LED to the distal right coronary is clear, but it's very, very tortuous. And so maybe this one is not easy. So we try. And the other channel is not clear. And I think for the retrograde is not, is the way should take time.
Sometimes you can just surf different channels, not visualizing it, yet the wire can go through. So you don't need to
what kind of this wire?
Always.
Seng.
This is Seng?
Yeah. Yes, yeah.
How about
so, okay, slowly, yeah. So it's the takedown. So advance my answer. Yeah, it's doing.
Let me ask you that. 永健，你们现在在用的是什么导丝啊
？It's sewing wire. The wire is sewing.
Dr. Sohail, how about giving a non-selective injection at the right coronary cusp?
But it's very hard to...
Non-selective injection at the right coronary cusp to see what happened to the ostium of the right coronary.
I think the Judkin is so deeply engaged, they don't want to inject right now.
I think it's
because that injection can descend.
So nice to take a picture to make sure the
No. 没问题。来拿一个那个150的那个 instant past。
Because now it's the wine is already in the is across the central channel. So
has made good progress.
Mike.
让它导丝。
Caster is the cassio. It's not easy to cross. So now we change another the mic caster. So it's a local product. It's called the Impass. So maybe you can show all the panelists. So it's the different design.
不，永健，你那个导丝难进到那个间隔区，你要不要把前降的支架用球囊先预扩一下？
So the wires is already across the cell of stent, but it's difficult to cross the septal channel.
我把那个冲一下，等一下导丝。
Use a balloon now to. Why did they take the corset out?
Yeah, they changed the wire because the wire could not cross the septal.
Okay, but
this is why
wire seems to have gone retrogradely quite too far, isn't it? Is this the wire?
This time we check the angiography is totally different with the angiography half years ago. At that time, the proximal RC is very clear, but I mean, maybe in the first curve of the RC is occluded. But this time, the ostium of RC is totally occluded. So it's very hard to engage the guiding catheter. First, we choose unplus 0.75, but it's very hard to find the RC. Then we changed to GR Jenkins R4, but it's still hard. Even we use the small branch to anchor the catheter, but it's still hard to engage guiding catheter. Yeah.
听得见我说话吗？
我现在能听见，但断断续续的。
现在就是我们会场看见你们的这个逆向的导丝已经走得很远了，是这样吗？
对的，对的。
那你们现在是换了这个 Cosel 在支撑，是不是
？No，
没有，是 instant pass。因为 Cosel 它那个可能比较迂曲又比较弯，非常难通过。
对
，OK， 不好意思。So you see this kind of the microstent is easy to cross.
Okay.
So I think it's not so in China, and some micro the cancer available, such as the steel and the micro.
So Dr. Chen, what's happening? Can you explain us what's happening? Can you explain to the audience what's happening?
Okay, thank you.
Get the corset down, so now they're taking a micro.
Okay, initially they use a Sony wire and the guidance of Cosel, because the set branch is very difficult to put the Cosel in. So now the Dr. Wu and his team changed to use micro Cosel. Is that clear?
You ask if they have any CT angio on these sort of osteal CTOs.
So now to check to.
Where's the micro is all the way up to the end of the wire?
No, not.
永健，你们现在的微导管已经过了这个右冠的这个远端了吗？
No, not. It's another channel. The channel connected to the proximal. Yeah.
Yeah.
So it's the take picture.
Okay.
The picture.
Okay. You can see it's in RC.
Okay. Yeah. It's not. So from the septal to the another
Yeah, now,
okay.
Now even Marco
okay,
the distal RCA, but the wire easily to get into the side branch, but not the main channel.
But you can see another wire in the LED also.
给我那个
LED also as a protection.
22150，对
，22150。The stent gets distorted, they have access for recovering the main feeding branch.
Okay. So
how much is the role of CT coronary in the CTOs? Especially like
maybe the first we try maybe
for preparation for planning. What is the role of CT coronary?
I need to see maybe the first try is maybe the use screen or the product.
Planning such CTOs.
Now, the antegrade guiding catheter cannot see the ostium of RC clearly. We cannot see the whole artery. So I want to change the unplus guiding catheter to Jenkins R4 in order to check the ostium position of the RC, so we can to manipulate the retrograde wire to puncture the circulation. So if we cannot see it clearly, maybe it's wrong way.
So now that we're going and retrograde, we
will
not need implants to Judkins.
No. Just the retrograde, because we.
现在你们逆向的导丝到了什么地方了？
我微导管已经放到那个远端下一帽那儿了。我要换，给我取掉逆向的导丝，取掉这个。但是我想
这个肖院长，其实这个钢丝呢是通过 septal， 然后有经过了一个像是一个心外往下的，它不是直接从右冠的远端。 然后到的是从中段直接到了，像一个 marginal， 像一个 marginal 过去的，通过一个 marginal 从 septal 到 marginal 过去的。然后我觉得现在这个师傅找那个前腔，找这个前下的这个右冠这个地方还不是特别好找，所以我觉得就直接就 retrograde wiring 直接往上穿，然后这样的呢，可能这个来。我当时觉得这个时候，我觉得还是希望能够用一个 UB3吧，这个往上传的时候。
哦，为什么不是现在往下一点？在这个。
OK， 好。
But I think this case is important because it tells us that you shouldn't stick with one strategy. So, clearly the antegrade wiring wasn't working for them, and they switched out very quickly to the.
Okay, so now we change one. No, not so now you change V3.
You have to be quite dynamic with the CTOs, and you have to change strategies very quickly.
V3, please.
Any time.
哇，这个方向不行，太容易动了。他应该也是在分叉这方比赛。我做一个 injection， 对，那个。
So it looks like they've got the retrograde wire up quite quickly with a microcatheter into the proximal right coronary artery, and the options now are to try and wire this true to true and come out in the proximal RCA segment and try and capture that wire. I think it's still going to be challenging to find exactly where the ostium is. That ostium is obviously diseased and progressed.
I'm feeling that you'll have to change the sewer wire to something more penetrating. And once you externalize the wire, then you'd be in much better position to get into the guider. And the Judkin is the right guider for this. You don't need amplifiers anymore.
Okay, that's...
I think like you were saying, we start off retrograde. Lots of people would have thought that, but for
okay, so this is the branch. That's the from the CTO.
You're going to need to do antegrade work, whatever happens in the case like this. And the question is whether you do that at the outset. Case. I think I would always start antegradely because you channels sections in the
otherwise, so we.
But switching out was a very good technique here because it meant that they saved a lot of time and they can work out now where the proximal RCA is and target their guiding catheter towards that proximal RCA.
But to be honest, putting the guiders in can sometimes be so challenging. I'd have one set of team putting in guiders and the real serious operators come in when the guiders are in position, the wire is anchored, so that they come in fresh and they can complete the case.
Dr. Sohail, if I may, with your permission, since we're waiting for the outcome of this live case, I just thought throwing this since we're all waiting, let's stimulate some conversation. What are the views of the panel as far as medical treatment for chronic coronary syndrome is concerned? What would you think about just medical treatment in similar cases?
The rule of retrograde CTOA is that the patient has to be symptomatic. So if the patient is asymptomatic, nobody would touch a complex CTO.
But what would be your threshold to, as far as medical treatment is concerned before?
When we say chest pain, it is with full medical treatment. So if the full medical treatment doesn't get rid of the pain, then you do a complex procedure like this, because they have complications. And if the patient is asymptomatic, one would not attempt these.
Absolutely, absolutely. But just for the panel, thinks is the full medical treatment in a similar case.
So a lot for the branch.
I mean, it's an important discussion point, isn't it? And I think, certainly in my practice, I ensure that the patient is on at least 2 anti-anginal drugs. They have to be symptomatic. And I like to usually get a perfusion scan done to demonstrate ischemia in the territory where the CTO is before I will think about taking on the case because of the complications, as has been mentioned already. So the complication rates are higher with CTO PCI, particularly if you're going to go through collaterals. So we know that retrograde collaterals or even epicardial collaterals have a higher complication rate associated with them. So, and you have that discussion with the patient in terms of, what the risk-benefits ratio is for that particular patient. And of course, let's not forget that medications also come with side effects as well. So often patients can't take medications because of the side effects that they are often faced with.
They're working with the sewer wire, it's very soft wire. And
so the panelists, so I just ask a patient. So after the RAD PCI up to now, so the patient is very stable, is the no symptoms. So, and the last 2 years, I also some cases with the isolated CTO in the right coronary. So we let patient to receive the treadmill or maybe the nuclear the test. So without evidence of ischemia, maybe in some patient with the isolated right coronary CTO, so the medication maybe is enough. But for this patient, so because the left side RAD and the circumflex is nearly normal, so maybe we will balance the risk and the infection. But for this patient, I think from the coronary angiography, the right coronary is not small, it's larger coronary. So we try to open. Now, well, it's really tough because the osteo occluded, and from here, it's the CTO, the segment, the distal CTO is just located as the branch.
Okay,
so maybe Dr. Zhao, maybe can we go back? We will check because the chain, the wine from the septal channel to the marginal. So can we try the wine from septal to distal right coronary? Maybe better. Do you think it's possible? Maybe we can go back to check. 看一下之前。来回放一下，再回放。
永健，你们是准备把那个逆向导丝换了，是吧
？Yeah, right.
哎，你准备换
I think it's right. The retrieval wiring is not the regular. So normally the regular wiring from the RAD to the distal, the right coronary, but now the wiring is not from the distal right coronary. It's from the marginal. So it's difficult to move forward the regular wiring.
那你准备换成一个什么样的导丝呢
No. So it's the doctor to try the new guiding cancer.
Okay.
我们想从前向啊，先看清楚右冠开口的方向，免得对侧导丝穿的时候啊，它这个比较麻烦。第一次做的时候，右冠近端还是有的，这次半年以后再复查造影，右冠全没了。
佘连院长，这是因为我刚才来晚了一会儿，这个因为上一个病人做个 CTO 时间太长，所以在做这个手术转播的时候准备的时间太短，应该在手术转播之前先把这些问题都解决了。不过这个提的确很困难，因为这个在这之前没有想到这个右冠概念的问题，这是给我们没想到的是 unexpected。
Okay, Dr. Wu said Since a successful CTO PCI for RAD, patient was asymptomatic, and also nuclear test did not find any sign of ischemia at the inferior wall. Right. So basically, there is no strong indication to do RCA CTO, but angiographically they found RCA is pretty large. So this is the only reason why they try to use. Secondly, they did the first attempt to open RCA 2 weeks ago. At that time, so the proximal RCA looks very long. So it means the CTO lesion is pretty short. But right now, just for live transmission, so the CTO lesion looks like pretty long. So probably it's caused by first attempt induced some complication, right? So now they change different kind of guiding catheter to engage the right coronary artery, but we all can see it's not easy to get stabilized.
Can they try a different wire, maybe a pilot to get towards the ostium and not the sewer wire? Sewer is too soft. Maybe the stiffer wire to go ahead in CTO retrograde.
They did not want to change the retrograde wire. So their plan is immediately after successful engagement of guiding catheter in right coronary, they will try to use very stiff wire to penetrate antegrade.
Okay.
Yeah, maybe because the picture, because we select the patient according to the angiography 1 year ago. But I'm sorry, so because for the patient selection, it's not very good for lab demo because it take a longer time. And maybe in 2 or 3 weeks, we should take the coronary again. And for the patient selection, but now the Dr. Zhao is to change the Jenkins, the GR, the guiding catheter. To just to guide the direction for the recurrent wire, because without the right coronary catheter guiding. So we don't know the rectal wire in the direction. So now we still use the pilot the wire, the guiding wire, the PTG wire. So for the rectal wiring. And we hope antegrade. So the It's antegrade?
Yeah, ST.
No, I think it's very difficult because no support.
Yes.
Because it's no support antegrade.
Yes. Try.
We try. So Dr. Zhao now is try the antegrade again. But I think it's very difficult. Yeah.
Dr. Sohail, what retrograde microcatheter do they have in right now?
No support.
They're using a sewer wire in the retrograde.
Okay, yeah.
They're still on the sewer wire.
This the pilot.
I would have
no support.
Stiffer wire, but their experience and and they I think are now trying to go integrate part of the way.
It's really difficult. Okay, no support. So it's just use the right the guiding.
What is the antegrade wire they're using in the right coronary artery?
This is the pilot. ST. This is ST.
前向，那你永健，你们现在前向导丝是什么导丝啊？
那叉 T。
啊？
XT。
哦，XT。
XT1。
哦，XT1。Antegrade wire is XT1. XT1.
Okay. It's an ST wire. I'm not aware of it.
Yeah, it's a wire from Auburn, ST1.
Which wire does it compare with? Does it compare with the Gaia series or Pilot series?
那永健，你们有没有想过去用一些其他的导丝？
Oh, no. No, I think,
就 ST1 是不是弱了一些？你没有用。
No, because the guiding catheter is just a GR.
Because the guiding is unstable, I think no more choice.
Yeah, the guiding, so we can't use the strong, the backup for guiding. It's so this is just 我觉得你这样的吧，还是从这个概念的意向，你从你意向的告诉我，他知道的，你知道往哪走就行了。给我拿一个来贴来，来贴，你意向。慢一点，我轻松慢一点。有一条缝过去啊，哦，那有一条缝。
OK。哎，永健，我们下面有一个讲座，你们先慢慢的做。
好的，那
讲座完了以后我们再回来。
Okay, good.
Okay.
So maybe it's possible.
Okay. So for the sake of the interest of the time, obviously we'll let Professor Wu do the case, and we'll have a break here and for a talk by Dr. Jawaid Sial from NICVD Karachi, and his topic will be leave less behind or taking with you, and it's a case of retrieval of broken wire. And he'll be giving a presentation for 6 minutes, and then we'll have a panel discussion for 5 minutes. While he'll be delivering the case talk, the team there in China, they'll be counting with their case, and we'll be going then back after a while. Thank you. Over to Dr. Jawaid Akbar Sial.
Bismillahirrahmanirrahim. Thank you, Dr. Zubair Akram. And I'm going to discuss a case as already it's leaving mess behind or taking it out. That we know this interventional cardiology is full of controversies, and nobody is right and nobody is wrong. There are a lot of things are in gray area. So basically, I'm going. Can I have my slides, please? Basically, I'm going to show you the two cases. These are real-time cases which has happened in different satellite centers of NICVD. So it's not a main center at Karachi. So next, please. Can I slide change it? Next slide. No financial disclosure. So these two cases, brief history of these two cases. One is a 55-year-old male smoker presented with acute inferior MI and with complete heart block. So this patient is complicated inferior MI, and this patient shifted immediately to cath lab where TPM implanted and proceed with primary PCI. And another gentleman was 70-year-old patient presented with non-complicated inferior MI. That patient was suddenly taken to cath lab and procedure has started. Now what happens? This is case 1 where you can see the left system, it's without any obvious significant disease, and the right coronary artery is dominant, and you see it, amid of it there is severe lesion, probably it is the culprit lesion which has been attempted with BMW wire. So here you can see the disaster, that a workhorse wire has been broken in that small branch, and a guider is showing it is not cannulated. So number 1. Number 2, what happened to second case? You see there is disease in left system as well, and patient has severe disease, moderate disease in mid RCA. Again, that is right dominant circulation, and there is severe disease in distal part of before bifurcation. This nasty movement of distal portion of the wire you can appreciate, probably it doesn't look into the vessel. And what happened next? Probably you can visualize that whole wire is uncoiled and broken, and proximal end comes into the ascending aorta. And in next picture, you can see the whole course of this wire. Now, these are the two different kind of cases in the cath lab. So, how to bail out these situations? I want panel experts, their inputs for those two cases, and then I will show what we did, what I did in these cases. We may start from General Sohail Aziz.
I'm not sure how the first wire got broken and how it got left behind. Sometime if you meet a dead end and you twist very hard, these wires can get wedged in, and the distal portion is like a coil, and you start to pull back, it unwinds, and then a portion is broken off, and so it's probably aggressive pushing for a workhorse wire, and so that's probably one reason. And if that happens, if there's no flow occlusion, I just go and treat the main vessel and stop there.
So you want to leave this portion in the vessel?
If this, I can't see where the back end is. If I can, my feeling is, if it's hooked in very deeply and you pull it hard enough, it unwinds and it breaks. So even if it has a very good snare before you can catch it and pull it out. So simply by getting in the guider, inflating or trapping and pulling would probably not be good enough for me. So that's my feeling. It's going to be very tricky to pull it out, but if you can get a good snare, we catch it in a snare, and we then have a portion which can be snared, because if the aorta is big, it's very difficult to catch a wire. It's easy to snare it in a small vessel, like the pediatric guys do. They take the vessel in a small vessel and then they snare it. So if you can get a good snare, it may be possible to pull it out.
Dr. Rosalie?
Most times than not, I would weigh between the risk of taking something out and also trying to, or leaving it in. A case in point, for example, if I got a stent which is dislodged, I tend not to take it out anymore, because there's no risk of thrombosis in the stent, especially if it goes through a lower limb. So in this case, if the distal tip of the wire for the first case is really lower down from the stenosis, right? If it's short tip and it's very difficult to take it out, I may want to leave it alone. But for the second case, I would try to take it out because it's throughout the whole length, and I would try to use a snare to try to pull it down.
Dr. Sohail Khan, do you have any?
Yeah, I echo those thoughts. The first thing to do when you encounter any complication is to decide whether you need to treat it immediately or whether you have some moments to think. And this is one of those complications, which you have some time, so you can think things through. In the first case, it looks like the distal wire has snapped, and then your decision then has to be whether the risks of leaving it in place are lower in terms of complications than taking it out. So I would probably think about just leaving that distal wire where it is, because I think the risks of taking it out are probably going to be higher.
Professor Mansoor, you are also busy in doing these kind of complex cases. Do you have any experience of this broken wire?
Yeah, I can recall one case, but usually broken wires are seen with CTO wires, not with these workhorse wires. And interestingly, was it a long case? Did he have to manipulate a lot? It all depends on that. And of course, the second one, with the long wire, why it got broken down? Did it have a fault before you used it? Because it's very unusual for it to fracture from the shaft, because it is a coil which stretches out. So I just wonder what really happened. If it's that, there should be no problem. If there was a faulty shaft, no problem, you can snare it out. And regarding the first one, I would really like to know what happened. Because was it a long procedure? Did it got stuck up? If it got stuck up, then you got to be a lot more careful, because pulling it out may not be free of hazards. So you really have to know. But of course, best is out than in.
Okay. As we have a limitation of time, so can you have my slides, please? So let's see what we did, how this patient. So this is the first case where another wire was taken and probably proximal part was in the mid right coronary artery, and it has been interrupted with several multiple rotations and then taken out. This is the first case. It seems to be quite easier because in second case the proximal end was in aorta, and this is a wire. This is a picture of wire once it has been taken out after entangling with other wires. And because they both cases occur in both are different operator in different satellite centers. So again, that same strategy was applied to it. And these are in smaller towns, so we don't have snares at that, but people used to make their own snares. If you are aware, they're putting a balloon, then taking out distal part into the guider, then inflating balloon, then artificial snare. But even that didn't work. In the first picture on the left, you can see that a snare has been made and tried to take out that part. It was interrupted, but as this wire was uncoiled, so it's impossible to take it out. Then this is the final shot, and this case was immediately transported to Karachi and ICVD, where surgery was done and this piece of wire was taken out. So these cases are well out in different ways.
So what surgery was done? Where was it? Proximal? Oh, cabbage, okay. Yeah.
So, 2-3 slides regarding broken wires. It's a rare complication of angioplasty, and we all are doing a lot of procedures these days. That is 0.1 to 0.8% of this incident can occur, and despite development of more flexible and high quality guide wires, the incidence of complication is not decreased. So these are certain things or certain risk factors where you can encounter these complications and wire breaks. And management option is conservative, interventional or surgery. Conservative, definitely if you don't take out, then conservative is another option, and you can crash it with stents. So after doing a lot of procedure, you need to get some time take out for recreation. Thank you very much.
Thank you, Dr. Jawaid Sial, for your strategy of retrieving this broken wire. Now we have got another talk, and that is two-stent strategy versus single-stent strategy. It's a case-based, and the case will be presented by Dr. Naeem Hamid from Faisalabad Institute of Cardiology. He'll be presenting his case in 5 minutes, then we'll have a panel discussion for 10 minutes, and then finally Dr. Naeem Hamid will tell what is his approach to such cases. So over to Dr. Naeem Hamid from Faisalabad Institute of Cardiology.